Now I would like to call upon Dr. Sandra Chandramouli to tell us more about the Bynocs system of amblyopia therapy.
Thank you very much, Shilpa, for the kind invitation. And I think all the previous speakers have done a tremendous job of giving you a lot of insights into what are the newer therapies in amblyopia currently available. So how many of you are actually practicing binocular therapy in amblyopia? Okay, so very few hands. I think at the end of this session probably it may improve. And so definitely before you start on any amblyopia therapy, the first thing that you should make sure is the refraction and glass prescription. So unless this is done, none of the amblyopia therapies will work. I think this is extremely important. Because there are many times when we have a wrong refraction and we think it's amblyopia, it takes a lot to get the correct visual acuity in a child. So unless you are very much, like you have a lot of experience, you may go wrong in the refraction and glass prescription. Traditional therapies, all of us has talked about. Occlusion definitely remains a mainstay. There are many conditions still where you will not be able to do the binocular therapies very well, especially in cases where there is a large angle strabismus, very dense amblyopias, very young child, less than the age of 6. You cannot expect to do a binocular vision therapy. So occlusion still remains, immediately after doing a pediatric cataract surgery, you may have to start on occlusion. That will be the step 1. The other therapies that we are talking about are in older children in mild and moderate degrees of amblyopia. Penalization and PEDI guidelines can be followed to these. But definitely there are a lot of parents that we come across who are not able to do the traditional occlusion beyond a certain number of years. It is easy to do it in a preschool child, but the same in a school going child or in an older child, they do not get the time or the number of hours per day to be able to do the traditional therapies, poor adherence, and they have a lot of social and psychosocial implications of occlusion. When you ask them to wear the occlusion patch to school, it is not an easy job. And the child has a lot of emotional difficulties in doing the patching, and atropine definitely has light sensitivity issues. And another thing is amblyopia per se does not address suppression, and you are not looking at binocular, you are not treating it as a binocular disease. And there are very few publications on how just occlusion, how can it, whether it can improve your binocular vision and stereopsis, to what extent it can improve, that we have to see. So definitely, as all the previous speakers have mentioned, it is not only an acuity loss. So once you stop thinking of amblyopia as just an acuity loss, then you will definitely look towards the binocular therapies, whatever mode it may be. Amblyopia goes way beyond acuity improvement. You have a lot of issues with depth perception, scanning and tracking, as how Dr. Shilpa has very nicely shown. The handwriting improves. There are a lot of parents who say, there was one parent who did binocular vision therapy with me, and after 2 months she said the kid is in 10th standard. That was the first time that the child has actually read the text by himself before an exam. Otherwise the mom used to read it out to him. So that was the fate of a 10th standard child, when for the first time before an exam the child could actually read the text by himself. So depth perception, scanning and tracking issues, contrast sensitivity, motion perception, peripheral vision, are we even looking into all of these? So unless we look into all of these, we do not know whether we are treating amblyopia successfully at all. But the good news is, brain is, there is a lot of neuroplasticity in the brain. It does not end after a certain age. So how did these therapies come? It were all promoted initially as adult amblyopia therapies, where there has been an injury to the good eye. The people who are amblyopic are very prone to injuries, especially in the good eye, because of poor vision. And when that happens, there have been some reports of how the vision in amblyopic eye does improve even in the adults. So that's how the neuroplasticity studies came into play. So newer concepts look at amblyopia therapy as a binocular vision training, looking both eyes as a team. The goal is to break the suppression first and then to enhance the binocular capacities. Improved reading ability, better academic performance, and definitely better sports performance. So if there is an amblyopia, there was one patient whom I had who was an engineer, but his thing was in cars, and he had to look at the speed of the racing cars. He was employed somewhere in Germany, and that time he found a difficulty with amblyopia. He had a mild amblyopia, 6/12 and 6/6, but he could find a lot of difficulty with his line of work, because there is a difficulty in motion perception, and the speed at which they notice things is definitely lacking. So coming to binocular therapy using dichoptic stimuli, Dr. Magdalene has given a basic, there are two basic types of these dichoptic stimuli. One is the type of therapy which she has described, and I'll be talking about the Bynocs system. What do you mean by dichoptic stimuli? There are two independent stimuli to each eye, and that requires integration under binocular viewing conditions. So you reduce the contrast to the normal eye, then that will be matched to the amblyoptic eye. And as the patient's performance visual functions improves, the contrast difference between the two eyes is gradually made equal, and the visual acuity gains follows the improvement in binocularity and contrast sensitivity and stereopsis. So all of them improve together. As you start recording the improvement in these patients, many a times you notice that the BSV and the stereopsis is what will improve initially, and that will be along with that the visual acuity improves hand in hand. So Bynocs is a cloud-based software for the management of computer vision syndrome and amblyopia. So they have various platforms. The diagnostics platform is called Bynoptics, where you can do the assessments, and the therapy platform you have the Bynocs Amblygo, which is for amblyopia. You have the Bynocs D-strain system, where you look at computer vision and digital eye strain and non-strabismic binocular vision disorders. And the other therapy is also there for improving the contrast sensitivity in like post-LASIK patients and post-adult cataract, especially with the premium IOLs. There also you find that for a few sessions, and every 20 sessions we call them back to the clinic just to see how it's going on. So the active graphic components can be seen by the amblyoptic eye, and they are filtered out for the other eye, and both has to fuse to in order to see the details. And since it is games, it is very easy for the child to do this kind of program. It is not there is no difficulty in doing it. The children are not scared of the program, and they have to play these games for 1 hour at least for 5 days a week. So minimum of 5 days a week should be done. And in our experience, we see a good initial improvement. There will be some improvement in 20 sessions, and we do at least 40 to 60 sessions will be needed. That will be translating to around 2 months of therapy. So 2 to 3 months of therapy. Beyond 3 months, we do not advise them to continue, because some amount of once they do not improve between 2 sessions, they are unlikely to achieve a further. They reach a plateau for their capacity. So the company promises 2 to 3 logMAR lines of improvement at the end of 2 months. So this is how it is. The comprehensive eye clinic examination in the clinic, followed by selection of right important is extremely important. Right patients in the thing, you rule out the presence of manifest strabismus, you rule out suppression, you rule out microtropias, and in the presence of strabismus it will not work. You have to align the eyes before you go into therapy. And enrollment followed by virtual training, and then reassessment by the Bynocs optometrist and also by us in the clinic. So as I said, the inclusion criteria, it works very well in mild and moderate degrees of amblyopia. Usually a BCVA more than or equal to 6/60 Snell lens. Foveal fixation is important. There should not be any tropia more than 5. You have to treat it with prisms, and then you start the therapy. And all amblyopia patients willing for computer-based therapy, they should have the requisite setup at home, or they should have somewhere where they can go and access a desktop computer or a laptop. So severe amblyopia, in our experience, it doesn't work very well. Eccentric fixators and those with tropia doesn't work very well. So you record the BCVA using Snell lens and logMAR, and you do an orthoptic evaluation, motor, sensory. All these parameters should be recorded baseline. Do the 4 prism base out, dynamic and cyclorefraction, slit lamp biomicroscopy, fundus examination or OCT to document the foveal fixation, and then the correct diagnosis. It can be aniso, ametropic, strabismic, meridional, mixed or sensory groups. Following this, then you need to assess the size. So through the Zoom, when the Bynocs optometrist logs on to the patient's system at home, they do see the size of the patient's laptop and desktop. It's calibrated, and there is a contrast calibration also done with the help of the red-blue anaglyph glasses. And at home, the patient along with the enrollment, they do get a measuring tape and a scale, so they can measure the distance at home and mark out. So they have to measure the distance visual acuity and near visual acuity in the area where they are doing the therapy at home. The room light illumination at home is also important. We advise them to sit in the same place every day because the computer has been calibrated for that. And heterophoria measurements and binocular vision with worth 4 dot and near stereopsis. So all these are recorded at the initial assessment, and then they are given a demo initially with the maximum brightness so that they understand it well. And after the demo, the settings are informed to the patient with the do's and don'ts, and every 10 sessions they get an assessment via Zoom with the Bynocs optometrist, and every 20 sessions we see in the clinic. And without completing the 10 assessment, the next set of therapy sessions cannot be accessed. So this is the monitoring. We can also see from our system how well the patients are doing at home, like the visual functions and your stereopsis, BSV, and whether they are doing the sessions every day, the time for which they are doing, all that can be seen by us. Just to have a, so this is not possible with the traditional treatments, like for compliance for patching, it's just their word for it or they write down in some notebook, but here actually we can see how well they are doing the therapy. And home visit guided sessions, so every 20 to 30 session we see in the office. There are some patients who do not have the requisite arrangement at home, then they can come every day and do also if they are from nearby. So here I think, yeah, can you please extend it? Okay. So this is the monitoring system which they can use at home, as you can see, and these are the various games the patient has played, and we can see the whether it's very easy for us to understand whether they are compliant or not, and how the visual acuity is improving. As in the graphs you can see, the logMAR vision acuity has improved from 0.45 to 0.1 at the end of therapy. So that's a 3-line improvement there. So the minute you look at the graph, you understand the patient is doing well. So coming to just for an idea about our results, we have done 74 eyes so far, and these are the demographic characteristics of the patients. As you can see, many of them, there are some of them below 6 years. If they are very intelligent and they can do it, we do enroll them. There are some patients aged 4 or 5 also. Many of them are between 7 to 10 or 11 to 19 age group. And so you can see here that before therapy, after therapy, all of them are having near binocular vision. 100% of the patients are having. And prior to the therapy, 6 patients had near suppression. After the end of the sessions, all of them had regained BSV. And for distance, initially around 74% had, and at the end of the therapy, 98% had gained distance binocular vision. 15 patients had suppression before the therapy. At the end of the therapy, only 1 patient had distance suppression. So there you can see the difference in distance. While near, many of them do have near BSV at the start of therapy, especially in anisoamblyopia. But at the end of therapy, you see that distance suppression has almost gone. And you see the stereopsis levels. Initially, only 9 patients had good stereo acuity levels. But at the end of therapy, around 33 patients are having near normal stereo acuity. Or definitely they have improved a lot in the stereo acuity levels. Distance stereo also, you can see initially only 3 had some amount of distance stereo, but after therapy around 21 patients had normal, 23 patients had even like 120 to 480 stereo levels. And this graph shows the levels of improvement as to before and after dichoptic therapy. There are a lot of patients who had improved by levels like 1, 2, 3, 4 or 5 levels of stereo acuity after therapy. And you can see the improvement between the different types of amblyopia. Definitely ametropic and anisometropic amblyopia does very well. The best benefit would be in ametropic, but there is no other way of doing treatment in ametropic amblyopia. Just by wearing glasses, many of them will still remain at 612. They will still not have good stereo acuity levels. Ametropic amblyopia, once you enroll into any form of binocular vision therapy, they get very good improvement by 1 month. There are few patients with pseudophakics, but they were moderate amblyopia and they improved. Strabismic, once you align, we had pretty good results. And this shows the comparison of patching versus Bynocs. So those patients who are on patching therapy prior to the start of Bynocs, you can see in anisometropic we had 26 patients. In the initial, before starting occlusion, their mean visual acuity was 0.45. After patching for very many years, the acuity was 0.43. That is why we had started them on binocular vision therapy because they were failed occlusion group. And you can see after dioptic therapy, the mean visual acuity has improved to 0.26. So even patients who have failed patching, you can enroll them with the Bynocs or any form of binocular vision therapy. Ametropic amblyopia also, there is no effect of the patching is not done anyway, but after dioptic there has been improvement from 0.3 to 0.1. So, and ametropic amblyopia, they were wearing glasses for at least a minimum period of 3 months before we started them on dioptic therapy. So it is not just by the wearing glasses alone. Just by wearing glasses, they did not improve. That's why we had put them on dioptic therapy. In the patients who were pseudo-fakes, similarly, similar to the, we can see from 0.33 to 0.30, but then after dioptic it has come to 0.1. Strabismic, for you don't see that much of an improvement, but you see from 0.62 it has come to 0.54, but there is some improvement. It is not like they didn't improve at all. So in the together all the patients, when you take, it was 0.46 to 0.44 after patching. After Bynocs it comes to 0.28, and we did follow up the patients for a minimum of 3 months after stopping the therapy. You can see that the visual acuity what we gained is maintained. Very rarely there is a drop by 1 line in our experience. Minimum of 3 months we have followed up, maximum to 1 to 2 years also. So they maintain their visual acuity even after stopping the therapy, which is very important. It's not a temporary thing. So you can see here, like 33 patients, 33 eyes, mean vision was 0.20 final, and after 3 months of minimum follow up it is 0.21. So not much difference. And similarly BSV, stereo, all are maintained. So this is again the same thing. The number of patients who had improved by 1, 2, 3 or 4 levels of vision or stereopsis following Bynocs amblyopia. The important thing is to choose the right patients. If you do not choose the right patients, you are going to dilute your results and you will say that it doesn't work. But once your inclusion criteria and exclusion criteria are well set, then I would definitely say that binocular vision therapy has a lot of advantage over the traditional methods of therapy. And technological developments, and maybe it is an evolving field, there may be a lot of improvements coming up in the future. And I think anybody who has further doubt or would like to know about Bynocs, I think the stand is it is there, the stalls are there. I can see Mr. Oliula also sitting, and any of you can contact him and he will be able to give further details on this. Thank you.
Thank you, Dr. Sandra. I just have a question to you. You're using the filters of red and green. Is it any
red and blue?
Red and blue. Is there any significance you should put in front of the amblyopic eye or anything like that, or
Yeah,
do you
red
reverse
before the
it?
amblyopic eye. Red before the amblyopic eye.
And then you reverse it.
Yeah.
Any significance? How does it work? Like red, blue? Because we all are aware of red and green. Like that has been proved.
Oli, any comments on that? Why you have chosen the colors of red and blue?
If you see,
I think she's more curious about the blue part.
Yeah.
is that so? I don't know. I thought the red
Not
was very
the red
difficult.
part, but why? It's a form of dissociation.
In contrast to if when you have your even for your words for dot test, you have red and green.
Yes.
So
See,
if
the
you,
way they have designed the games so that you want to reduce the contrast in one eye, and you want certain elements to be seen by the amblyopic
Yeah,
eye and
so
certain elements to be
probably-
seen by the
So
normal
you
eye.
said the red light, your red glass, you're going to put in front of the amblyopic eye.
Right, that Oli here, sorry. Thank you, ma'am. So why we use these two color filters is just to dissociate two eyes. Now, why typically red and blue? Because it can be commonly available to the patient. And when we use these filters, the red is very difficult to suppress. That's why we put in front of the amblyopic eye, because it has a longer wavelength and you cannot suppress. And it also has a facility or the kind of stimulating the foveal cones. So that is another aspect we look at. So these are very good tools. And then blue, typically, because it is commonly available, we have chosen. But green is, so we have a program where you can even choose the red, green. So always red is common, but either we choose a green or a blue filter.
Yeah, but the thing is, I think nowadays we are giving the filters to the patient
Correct.
along with it, because what happens is if you ask them to choose, sometimes the quality of the red-green glasses that we get is not uniform. It is very difficult to find a good pair of red-green glasses. Even in our clinic, there are a lot of monocular clues available. So I would not suggest you to just buy something randomly use. It's always better to use something which is provided by the company. Because if it doesn't work, we can always tell them.
No,
Yeah.
more typically when you do a Watford dot test in clinic, so predominantly if you look through the green filter, you would see all 4 dots visible.
Yes, yes.
And
That's why.
that is where you don't see a true dissociation happening and always false positive. Like you have suppression somebody, but unfortunately because
In
of
my
the green
clinic, there are now
filter,
10 pairs of red-green glasses. There is only one that works.
one that was.
Yeah, right. Before checking on patient, always we have to see through that.
So that can be minimized with our program where we actually calibrate.
That means the quality of the product
Yes.
is not a standard
Yes.
product. So
Very true, ma'am.
we also have to see that we get quality products.
So we provide, along with the program,
okay.
we provide to all
Yes.
patients.
I think we are.
I think we are running late
Yeah.
of time, so we'll carry forward the question. Thanks all for attending. Yeah.
Thank you for attending the instruction course.